This is the patient using tamsulosin for benign prostatic hypertrophy who experienced severe IPHIS on his fellow eye. The APX is inserted through the 19-gauge side port incision until the pivot pin is seen inside the anterior chamber. The device is open about halfway, the terminal tips are positioned behind the iris sphincter, and then the APX is slowly opened and released. The same procedure is done on the opposite side. No intraocular manipulations with any additional instrument are required during insertion of the device. ACCC is now easily performed using Utrata forceps. Phacoemulsification is performed using routine surgical technique under direct visualization. No iris prolapse or billowing was seen throughout the procedure. Note that there is no element of the pupil expander between the phaco-tip, the iris, and the lens. Aspiration of the cortical fibers is done using bimanual irrigation and aspiration. The entire ACCC is clearly visible through the enlarged pupil. PCIOL is implanted into the bag by direct visualization. The APX device is removed by using the designated forceps, simply by closing the forceps and pulling out the pupil expander. Following aspiration of the OVD, the pupil returns to its preoperative size and configuration. This is a diabetic patient with a 4 mm pupil non-responsive to pharmacological dilation. A cohesive OVD is injected also behind the iris sphincter to create a space between the iris and the lens for an easier and safer positioning of the pupil expander. The second 19-gauge incision is deliberately not exactly opposite to the first one, to create a trapezoidal-shaped opening. The APX is slowly opened about halfway, the terminal tips are positioned one by one behind the iris, and then the device is completely opened and slowly released. In case the tips are not positioned well, the procedure is repeated. The APX is regrasped, closed, repositioned, and released. No intraocular manipulation is ever needed to position or to remove the APX. Lens removal is done by using the routine surgical instruments and techniques. There is no element of the expander between the phaco-tip and the iris, and the pupil expander does not interfere with any surgical maneuver. The capsular bag is filled with a cohesive OVD to allow IOL implantation under direct visualization. Removal of the APX is done using a disposable forceps, simply by closing the device and pulling it out in a matter of a few seconds. The pupil typically returns to its original shape and dimension.